I see who's not here. So Delegate Saab is in. Delegate Bandari.
Yeah, he's in.
He's in.
Yep.
I have a number here that I don't know. It's okay. We are live streaming now. It's 371. It's a 371 number. That person needs to come in. I don't know who that is. And we are live streaming, so I'm going to go ahead and get started with this meeting. Good morning. This is the Insurance and Pharmaceutical Subcommittee of the Health and Government Operations Committee, and we welcome you and apologize for the technical difficulties that we've been having this morning. Thank you very much for your patience. We hope that you were not held in the waiting room too long and you were able to find some things to do while we were waiting. I have a few notes just to start off with. We have until 12:30 today, and I'm sorry now we have less time than I had hoped, but we're going to try to end this meeting at 12:30 today. People who provided any feedback, whether it was oral, written, or both, on any of these bills in the original hearing, were invited to participate in this subcommittee meeting. Some others who are interested in the bill, we hope that they're watching on Facebook Live. We had a hearing on all of these bills, so this is to be considered a work session. This is not a second hearing. A few bills will be, for a few bills, we're going to just provide some information for delegates on the subcommittee, and we won't be voting on them today. A couple of bills I do hope to vote on today. And the process that we're going to follow is we are going to take one bill at a time. Those who are involved in that particular bill will be invited into the room. If you're not in the next bill, then we're going to ask you to go, we're going to take you back into the waiting room after the bill is done. Bring you back if you need to be, if you have another bill. Lisa Simpson, the counsel for this committee, will describe the bill first, tell us what it does. Then I will give the bill sponsor, if they're able to attend, an opportunity to speak to the bill for just a moment. And then I will ask if anyone has any information that is additional to what was provided to us in the hearing. And if you do, I believe everyone has the capacity to raise their hand through the reactions function.
Yeah, the only people that are on this are the people in the committee.
No, not everybody's on the committee. No, we've got a lot of people who are not on the committee.
Oh, never mind. A lot of people who are not on the committee.
Yes, that's true. Because it's participatory. There's Delegate Young, good. So we're going to ask anybody who has additional information on a bill, like I said, beyond the hearing, and then the committee will have a chance to ask questions. And I will, and we'll watch our time in terms of where we think a bill is going. So with that, we are going to start with House Bill 167, Health Insurance Out-of-Pocket Maximums and Cost Sharing Requirements Calculation. Lisa, want to tell us what the bill does?
Sure. House Bill 167 requires carriers to include any payments made by or on behalf of the insured subscriber or member when calculating the overall contribution to an out-of-pocket maximum or a cost-sharing requirement.
Okay, and Delegate Young, did you want to say anything at this time?
I'm actually Delegate Young's staff, so I'm going to defer to you.
Okay, great. Well, my purpose this morning on Bill 167 is to get more information. So I have invited Andrew York, who is currently the Executive Director of the Prescription Drug Affordability Board, but who has a long and extensive background in pharmaceutical pricing and the relationships to insurance. So he is here for informational purposes only. This is a bill where it requires a lot of understanding for us to make informed policy about. And so that's why I've asked Mr. York to join us to make sure that the subcommittee had the information it needs in order to be, in order to make good decisions, good informed decisions. So with that, Mr. York, would you take it away, please?
Chair, thanks so much for the invitation. So I think I should start with just a couple disclaimers, and also thank you to the subcommittee for the chance to present to you today. So I think I think my purpose here is to just kind of give a crash course on what copay accumulators are. And then we also have a table that we're going to walk through, because unless you actually see the numbers, it's actually a little difficult to understand exactly how they work. So I was just going to give you a quick rundown. Basically, at the highest level, we're at a place where we have very expensive drugs, and you have payers that are using different tools like deductibles, which is an amount that you have to pay out of pocket before the benefit kicks in. Co-insurance, which is generally based on the actual price of the drug. You pay a percentage of the drug rather than flat copay. And then they built in protections called out-of-pocket maximum. So basically, to protect the patient, you say, once you pay this much out of pocket, then we have a much more generous benefit structure. And then in response to that, manufacturers, so basically that puts more risk onto the patient and increases their out-of-pocket costs. Then in response to that, manufacturers use tools like copay coupons to reduce the risks for patients. But basically the payer still has to pay the full amount. So what it does is it reduces the risk for the patient and kind of short circuits the plan elements that they're using to manage those costs. And then also, so basically what you're trying to figure out today is how you should be counting things like copay coupons towards different benefit structures, such as the deductible and the out-of-pocket max. And if you don't mind, I'll give you a super quick history on how we got here. So just a general history of how pharmaceuticals, got to a place where we have, some extremely high-cost drugs and high deductible health plans and things like that. So basically, until the 90s, folks were paying out-of-pocket for drugs. They generally weren't covered under insurance. This was kind of the era of the early blockbusters. Those drugs were in the hundreds of dollars, not the tens of thousands of dollars that we see today. But it was still enough for patients to feel the pain on that. So then insurance increasingly started to cover drugs in the 90s and 2000s. This often included copays, which is basically just a flat amount, right? You pay $5 a month for your drug. But then just coincidentally, and I have, I'll just say that the cost of drugs really started to explode as you started to see more general insurance coverage. And then insurers basically in response had to start managing those high cost drugs. And again, those came through things like high deductible health plans, which have been increasing over time. And again, when you start having high deductible health plans, you also need to build in protections with the out-of-pocket maxes. Basically, once they started putting the risk on the patients through the deductibles and co-insurances, manufacturers started providing copay coupons. And I wanted to give a quick history on copay coupons. So this is a gross generalization, and I hope that any other speakers today can kind of push back on any individual points. This is more illustrative. But basically, copay coupons kind of started when brand names drugs started to go off of patent, and then the generic would come to market, and the copay coupon would make it cheaper for the patient to use the name brand drug. So they pay the out-of-pocket cost for the patient, but then the insurer was still on the hook for the more expensive brand name drug. What we're seeing more commonly now is that these copay coupons are basically meant to get patients into more generous portions of the plan coverage as quickly as possible while minimizing the hurt on the patient, right? So minimizing the risk, minimizing out-of-pocket costs. So it's supposed to help them get through the deductible quickly and get into things like out-of-pocket maximums as quickly as possible. And then one thing I also wanted to flag, but that kind of short circuits the tools that the plan is using to manage those high-cost drugs. And then the last thing I wanted to flag, I'm coming from the federal side, so I was at CMS immediately prior to that. And I think it's worth noting that
Matt's there.
It's worth noting that copay coupons are actually assumed to be banned from federal programs. So there was a 2014 OIG report, which basically says that functionally copay coupons violate anti-kickback statutes, which is basically you can't pay someone to use a federal service that then comes to you as a reimbursement for federal services. So you can't pay someone to use your drug, and then that comes you have an insurer basically paying them. So on the federal side, they've actually been banned, so this is primarily a commercial sector issue. So basically, we're at a point where drug costs are high, plans are trying to push some of the risk onto patients as one of the potential tools to manage those high cost drugs, and then you basically have to decide if we want the plans to be able to maintain all the incentives that they have. So if you want, I can pull up the table now and just kind of walk you through what this looks like on paper. Any questions just on the oral history of copay coupons and copay accumulators?
Please use the raise hand function if you have a question.
And I guess I should also define what a copay accumulator is. Basically, the copay accumulator says that anything that is paid not by the patient, so by, for example, a manufacturer, does not count towards things like a deductible or the out-of-pocket cost. So basically, those plan designs are meant to have all of that money come out of the patient's pocket to ensure that they're conscientiously using these high-cost drugs. You can, I think it's a broader conversation on if that's how you want patients to bear risk, but that's currently how our healthcare system tries to manage higher cost services.
Okay. I don't see any questions. So, Ms. Bowles, you have a question?
Yeah, sorry, can you hear me?
Yes.
Thank you. Yeah, I just wanted to go back to the point that was just made kind of about the utilization of copay assistance and sort of what types of treatments they're used for. You mentioned that, the evolution of them kind of came about as drug prices, got more expensive. And, I think from what we see on the patient side would be as more specialty medications came about, right? But going back to kind of who, what assistance is available for, the latest data that we've seen about copay assistance is that the overwhelming majority of it is available for treatments that don't have generic alternatives. So just wanted to kind of clarify that and see, how that fits into what we're talking about here, because, for the most part, it's a very tiny subset where there is a generic available. And, so in the case of these copay assistance programs, patients are, getting access to these specialty medications through utilization management protocols where, they first need approval from their insurance company to get that access. And then following that, are seeking the assistance. So just wanted to kind of see if we could maybe, talk about how that piece fits into this overall kind of history that we're talking through here.
Right. No, thank you for the comment. That's very important to note. And so I agree that right now they're primarily for specialty drugs. Specialty drug, there is no specific definition of specialty drug. They can have enhanced, like distribution requirements and things like that. But the real defining feature is the fact that they're just extremely expensive. So to your point, now the general purpose of copay coupons is to get patients through the risky portions of their benefit plan, the benefit design, into the more generous version. So coming back from my Medicare space, basically what we're seeing just as a general trend is in Medicare, there's something called catastrophic coverage, where you basically go through different stages of the plan, and then you get into catastrophic coverage, and then most of that risk is borne by CMS. And that's basically what we're seeing here, is you're basically trying to manufacturers, and I'm trying to be as impartial as possible. I think, this is, a push and pull of different types of incentives. But basically right now with the specialty drugs, we just, they're often so expensive that they push you into something like a higher benefit plan, or higher risk for the plan, lower risk for the patient. Now the goal seems, not necessarily the goal, but the outcome is that folks are generally getting into the higher, more generous portions of the plan quicker. So that's kind of what I see the version of the copay coupon is basically it minimizes the risk for the patient as you get into more generous phases of the plan. I'm not sure if this is kind of a general perspective, and the details really do matter, but I think your point is well taken.
Mr. Celentano.
Thank you, Madam Chair. Would it be appropriate for us to ask a question of Mr. York, or should we just leave that to the committee members?
You can ask a question. This is about gathering information.
Okay, thank you. Mr. York, could you expand a little bit on how you see, from the perspective of the Prescription Drug Affordability Board, how the coupons sort of, as you said, short circuits the carrier's tools to kind of reduce the drugs and maybe we should just be sort of heading in the direction that Medicaid and Medicare has done by banning coupons and asking pharma, just instead of using a scheme, to just reduce the cost of the drugs.
So the board does not have a position on this. I do not have a position about this. But, I think that's generally one of the key talking points, right? I think that, again, I tried to give the history because it explains that this is a kind of a natural push and pull from two parties that are trying to manage costs and maximize revenue. And then often kind of patients are stuck in the middle there. So, I think there's a number of different policy opportunities, and it's for different stakeholders to kind of advocate for their positions.
Okay. Ms. Rifkin.
Thank you. So, hi, Andy, how are you?
Good.
So, while I agree that there's a difference between when there's no generic substitution and when there is, my understanding, I just want to know from what I've read, to know if you think that this is correct, and if I'm wrong, I'd love to learn a little bit more. While that is a big component, there still are other brand drugs out there on a formulary that a patient could take, and they could be lower priced brand as well, even if there's no generic substitution. And so the way I see it, also insulates the cost of a drug for a patient, because essentially they've gotten the coupon, so they're insensitive to the actual price of that drug, and they're not looking at their benefit design to see if there's another brand drug that would be as appropriate. It may not be, but if there is a similar drug on the formulary that's less expensive, they don't even look for those alternatives. And so what that allows, in my logic stream, is that allows manufacturers to continue to increase the list price of that drug because people are insulated to the cost. They don't even think about it, or helps them maintain that high cost. They never feel the competition from the other brand drugs or generics to reduce their price. And that's part of the problem as well. This isn't just about when there's a no generic. And I just was wondering if I'm making this too broad, or if that's also part of the discussion.
No, I think that's a fair statement. So I think everything you said, that's all completely fair statements. I think that's actually something that I missed in my talking points is some critics will say that the reason that drug prices have been able to get so high is basically because of these installations, right? So basically you have plans that are taking the risk, and then no one, they're trying to do their best to manage the risk through things like, deductibles and other tools, but then you basically take away, that impact. So, the patients aren't feeling it. That's one of the most important stakeholder groups. So then you ultimately don't have them pushing back on some of these extremely high prices. And then I guess one thing I would also say is so copay coupons are obviously in response to trying to increase access for patients and reduce their risk on behalf of manufacturers. But it's also to increase utilization. So to Deb's point, it's to push utilization towards their drug versus other drugs, or if there's nothing else on the market, then you see kind of the phenomenon that I was talking about earlier, where you push folks into, the catastrophic phases or, total out-of-pocket cost basis as fast as possible.
Yeah.
But it is about, there is levels of competition within different classes of drugs, and reducing out-of-pocket costs for beneficiaries drives utilization for those drugs.
Thank you. I'm gonna ask the folks. I've got three people that I'm gonna ask questions. It's Dr. Worthing, Ms. Kaufman, and Mr. Schultz. If you would just keep your questions concise, please. And then I want Mr. York to run through the chart, and then we're gonna probably stop on this bill because we're gonna have information, and we will be able to have further discussion on the bill. So Dr. Worthing.
Thanks, Madam Chair. I'm coming at this as previously an advocate for the American College of Rheumatology. Rheumatologist. I'm a rheumatologist in Maryland. We give it probably an outsized sticker price for the medications relative to the number of patients we treat, to say the least. Two quick questions. I'd love to hear your thoughts on, we're hearing about this supposed increase or inflation effect of coupons on price. How much do you think rebates contribute to high prices relatively compared to these coupons, if any, if there's a difference? And secondly, we're talking about two kinds of drugs that people get in the pharmacy or shipped to them, and then what I provide to people, IV drugs or infusion drugs, totally different benefit structure. Not necessary to have coupons in the Medicare system. So I kind of doubt how HHS would have banned rebates if IV drugs required, or banned coupons if IV drugs were paid for a lot by coupons, but people have secondary insurance to pay those bills. Any estimate how many people in Maryland out of the maybe 120,000 taking a specialty drug, how many would stop taking their specialty drug this year if we didn't have this legislation enacted? Sorry about the complex double question.
No. So all your points are well taken. I don't have any guess. I don't know what the utilization of copay coupons is in Maryland. I don't know. I mean, the general idea is there are risks to adherence if you increase out-of-pocket costs. So that's a general, I think that's pretty well stated. So I think there is a risk associated with that. But I don't know, how many folks would, change their drugs or stop taking their drugs. But yeah, so sorry, I don't have a great answer on that. Did that address your question? It's something that I think we're certainly interested in. So we will be researching that. Oh, and then you asked about rebates versus copay coupons. They all feed in towards this, black box of like no one knows how much a drug actually costs, and there are no direct consequences for list price going up versus not. So I think they all are kind of fit into that same conversation. And I think critics would argue that all that opaqueness of that market allows for list prices to go up when you then also can say that the net price is not going up. Happy to get in the weeds on that on another day.
Ms. Kaufman?
Thank you. I just have a quick question, and we kind of talked a little bit around the edges of this, but just because you have a coupon doesn't mean you get direct access to that drug. You still have to go through utilization management, correct? And have that drug then approved by the carrier. So it doesn't circumvent the need to receive prior authorization, or if it's under step therapy, or if it's not on the formula. And we do have provisions in the law, in Maryland law, on all of those. So I just wanted to clarify that this doesn't necessarily mean that you short circuit the utilization management. You can only use the coupon after you've been approved for that particular drug. Am I correct in that?
Yes, utilization management is a broad term, and many of the tools still exist. So formularies, like you said, prior authorizations, those kinds of things. Those are all still on the table. But just in terms of plan design, if you are trying, like the reason high deductible plans exist is that patients are taking a higher risk, so you can lower premiums. Those kinds of things. So it's just saying that like one of the tools that's on a plan's table to manage costs and manage patient behavior is off the table, or it reduces the impact of that. So, but I do appreciate the clarification.
Mr. Schultz?
No, thank you. Thank you for having me, and thank you for giving this opportunity. And thank you, Mr. York, for coming on and answering questions. But Stephen Schultz from the Arthritis Foundation. I just wanted to, I think Dana was going to kind of took a big chunk of kind of what my question was going to be as far as kind of the utilization management tools like step therapy, which walks a patient through as a result of insurance protocols to get through cheaper alternatives or generics. And so patients would have already attempted a lot of options, so that when patients get to this medication that does have a assistance program, and I like to specify assistance because of coupon seems like it's a case where the patient's picking and choosing, where this is usually something that's set in place by the formulary, by the insurer. And so I think that, thank you, Dana, for asking that clarified question. And I think I'll just make one quick comment before passing it over as far as the patients are kind of caught in the middle, as you see today, by so many different parties. And right now, due to these high costs and due to things like COVID that we're dealing with patients having less dollars in their pocket, this type of assistance really helps patients afford their medications, stay adherent to their medications, and an accumulator puts the cost sharing back onto their shoulders, and hurts, especially given this time. So a bill like this can help. Thanks.
No, I appreciate the comments, and we don't have any specific stance on, whether or not copay coupons should exist, or we don't have a stance. I do think that, the one thing I can confidently say on behalf of the board is our priorities is generally patients and Marylanders, and they're probably the ones that are the least able to bear these kinds of risks. You have very large organizations on one side, very large organizations on the other, and patients are often caught in the middle, and that's, I do agree that we should try to minimize that.
Okay, thank you. I would like to have people just see the chart to see what the impact, the sort of comparing apples to apples. Can you share your screen, or do we have to do it from our end?
Let me try to share.
Yeah, you should be able to.
I usually consider myself a Zoom expert.
Well, this morning the gremlins are at work, so.
If someone wanted to guide me, is there I see participant, chat. Oh, share screen.
Yeah.
Oh, but I'm also disabled at this point, sorry.
Is it, so Brigida, do you have it on your screen, the chart?
On my screen, no.
I can send it to you.
Yeah, send it to me real quick.
Yeah. I'm sorry about that.
While she's pulling that up, I wanted to ask a question in terms of, and I think the chart might get to this, or maybe not. So the impact on the allowing the coupons to be a part of the co-payer is, for the individual at that moment, something that is, helpful. Can it ultimately contribute to higher premiums because of the way the calculations are done? I have seen one study that references that, but it's just one study, so.
Yep. Yeah, I would defer to my payer colleagues on the call to answer that. But in general, I think folks can, critics generally say, or folks say that copay coupons can increase overall drug costs. The plans are trying to manage those drug costs and keep premiums down. If you take away their abilities to manage that, then it can do things like increase premiums, or if you don't increase premiums, a lot of that just falls onto the overall plan sponsor, either the employer or things like that. So it is. Yep.
Yeah, I'm sorry. Is the chart the one that says Appendix A?
Yeah. Yep.
Okay. All right. Let me share the screen then. Sorry.
And this is very back of the envelope. I can send folks a link to an Adam Fine drug channels chart that he has a very specific perspective that he writes from.
There we go. You should be able to see it.
Yep. Perfect. Yep. So let me walk you through this. So again, very high level, but I just hopefully will show the impact of how the math works on this. And it is worth taking a close look at it if you get the chance. But this is our theoretical plan. You have drug A that's $1,000 a month. The plan design has a $1,000 deductible, 25% coinsurance, and an out-of-pocket max of $2,000. And then you have a manufacturer assistance program that provides it at $25 copays, but then has a maximum value of $1,500. So the first, the tables will switch. Table 1 is supposed to show what it looks like when there are no copay coupons. So if this is just how it works in the real world. So the drug cost is the cost each month. The plan amount is how much is reimbursed by the plan. And then the bill is what shows up at the pharmacy, and then that's split between the patient out of pocket and what a copay or assistance program would look like. And then at the bottom, you can see how that counts towards the deductible and then the out of pocket cost maximum. So in table 1, you can see in January, you have to meet your deductible. So the plan doesn't pay anything, and then at the bill, there's a $1,000 bill, and then the patient pays that $100,000. So then they meet their deductible. Starting in February, then the plan pays $750. And then the patient pays their 25% coinsurance, which is $250. And then that starts to count towards their out-of-pocket maximum. And then in May, you see that they hit their out-of-pocket maximum. where then the insurance plan is paying the full amount, $1,000, and then the patient is not paying anything. Pardon my background noise there. Does anyone have any specific questions on that, that table? So if you move to table 2, this is what it would look like. This is what it looks like without copay accumulators. So it basically means that the plan, the co-insurance, or sorry, the copay coupons paid by the manufacturers count towards, they basically are credits towards the deductible and also the out-of-pocket maximum. So if you look in table 2, you have this $1,000 drug. The plan doesn't pay anything because the deductible is not met. The patient pays their $25 for the copay coupon, and then the plan covers the rest of that for $975. But that still counts towards the $1,000 deductible. So then in February, the deductible is still met. The deductible is met, and then there's still credit on this copay coupon because it has the total value of $250, or sorry, still has a total amount of $1,500. So basically what's happening starting in February is the deductible was met. The plan now has risk starting at, so they're paying $750. The patient would owe $250 at the counter. So then they give their copay coupon, they pay $25, and then it's the manufacturer paying the $225, which is the difference between their coinsurance and the copay coupon. And then you can see that this amount continues to contribute towards the out-of-pocket cost maximum. And then they hit their out-of-pocket cost maximum in June at the same time that they would have otherwise. And you can see if you go all the way to the last one, the plan is paying $10,000 total. The bill at the pharmacy is $2,000, and $500 of that would be from the patient, and $1,500 is the maximum value of that that insurance assistance program. And I guess I should have compared that to the first one where in table 1, that entire $2,000 coinsurance is paid by the beneficiary, which is basically up to their out-of-pocket maximum of $2,000. Any questions on those two? And then I'll show you what the copay accumulator does. All right, so if we go down to the final table, so just scroll down. You have a copay accumulator, which means that only the patient's out-of-pocket costs count towards credit, they are credited towards the deductible and the out-of-pocket maximum. Are you able to scroll? There we go.
Yeah, sorry.
Okay, no problem. So you can see in this case, in January, you get your $1,000 bill. The patient pays $25 and the manufacturer pays $975. But only those $25 paid by the patient are credited towards the deductible and the out-of-pocket maximum. So then you can see that your out-of-pocket maximum is hit later in the cycle in August, right? So this basically makes sure that it ensures that the beneficiary still has to pay their full $2,000. It also maximizes the manufacturer's contribution, which is the $1,500. And then you can see in this case that the plan's payment, because they hit the more generous out-of-pocket maximum later in the year, the plan risk is lower. So they only pay $8,500 versus the $3,500 between the manufacturer and the patient. That was a lot of information very quickly, and if you don't really get to look closely at it, I wish folks had the chance to kind of take a close look. But does anyone have? So the general issue is that when comparing number 2, which is how it currently works, to number 3, which would eliminate copay prohibit copay accumulators. Actually, I'm not sure. I guess they are prohibited right now, or no, they're not prohibited. So we're talking. Basically, what would happen is the copay accumulators reduce the risk to the plans, increase the risk to the patients, and increase the risk to the manufacturers. And there's also a flavor of things called maximizers. I'm happy to tell you what they are. They're basically what they take the entire value of the assistance program and make sure that you hit that by spreading it over the entire plan benefit. And that just basically maximizes it, what the manufacturers would pay for the drug as part of this plan. So Sorry, I know it's tough, and this is actually very in the weeds. Does anyone have any questions? So, but again, to go back to the overall point, if you have accumulators, it minimizes risk to the plan, has high risk to the patient, and maximizes risk to the manufacturers. If you do not have copay accumulators, it helps the beneficiary get through the lower benefit part of the plans, and so lowers their overall risk, but it increases the risk to the plan. So I hope that's illustrative.
Okay, I have 3 questions that we'll take, and then we're going to need to move to the next bill. I'll start with Mr. Schultz.
No question. I must not have lowered my hand. I apologize for that.
Delegate Krebs.
Thank you, Madam Chair. Andrew, thank you. I wish the charts were bigger.
Yeah, sorry.
Really good examples to study.
We'll send Delegate Krebs.
Thank you. Andrew, is your prescription drug affordability board, are you planning to take up this issue as part of your overview of what you're doing?
We plan on producing a report that takes a comprehensive look at the pharmaceutical supply chain and reimbursement structure. This would certainly be something that is a topic. Whether or not we take a position on the value or good or bad, I think we want to provide the impacts and then suggested policy options, and then we will have recommendations. I'm not sure if we'll have recommendations on this specific issue, but this will certainly be part of the report.
No, I appreciate that, because there's so many unintended consequences depending on where your perspective is. So you've done a great job here, but I look forward to that because I think it'll do us well. Thank you.
Great.
Thank you, Delegate Krebs. Ms. Robinson.
Thank you, Madam Chair. And Andrew, thank you for what was a really good presentation. I appreciate it. My one question, and I just wanted to highlight this, I think sometimes you, like I, use a lot of terms of art. And so I think when we talk about risk to patients and plans, that has a very strong connotation if you aren't someone who sort of speaks the language. One thing I just want to have you double check for me. My understanding is that when we talk about the risk to the patient, any other patient in that same plan design would have that same deductible, that same out-of-pocket max. And so if Kim is on a drug where there's no copay coupon, she's still going to be paying that same out-of-pocket max. And if Andy is in that same plan design that does not allow for the accumulation, all it's doing is it's keeping the risk to Kim and Andy the same regardless of the coupon. If Andy's on the drug with the coupon, he gets the benefit of that, but it means that those patients for whom there are no coupons, they're still facing that same out-of-pocket cost, right? So it does sort of pick winners and losers based on whether or not the manufacturer of your drug wants to offer a coupon between the plan design, and at the same time, should that cost shift to the plan occur, tax premium, everybody sort of shares in that.
Oh yeah, I thought I answered
together.
and said yes, but
Yeah,
I'm still
so
on
I think that
till
is a fair assessment. So, and yes, I try to be really careful on the language that's used, the term of art. Unfortunately, it gets really in the weeds, but it also, as soon as you drift out of the terms of art,
no. And actually, I got to hear the school-based health center bill next.
Has kind of
Kim, you're not on mute. You're not on mute.
Pam, you're not on mute.
But to your point, basically, if you had patient A who has the copay coupon and patient B who does not have the copay coupon, they happen to be on the same drug, but just one person realized that they had access to the copay coupon. The person that has access to the copay coupon would pay less out of pocket. I think in both scenarios. Sorry, I'm pulling this up. But in terms of, like, I think the risk to folks that are not using it, I'm sorry, let me pull up my version of the chart.
I mean, I think I see it as the plan cost overall, increases. We think of the plan as the insurer, but really the plan are the people who are paying the premium, right? So that's who, have the potential to realize the increased cost. And I think your description of short circuit, the plan design was helpful.
Yes. Sorry.
Thank you.
Sorry about that.
Thank you. I would like to give Delegate Young, he's online now, I think, just a minute to to speak to the bill. And then, as I said, we're going to wrap this up, and we will make sure that the subcommittee has Mr. York's information. And if you have questions in the meantime, before our next meeting on this, I'd ask you to give them to me, and I can make sure that Mr. York gets them, and the whole subcommittee will get his responses. So Delegate Young, are you still with us?
I am, Chair. Thank you.
Okay, great, thank you.
Appreciate the courtesy. Just for a moment, I will be brief. I cannot present the information as intricately as Mr. York did, and thank you for all of it. It benefits everybody to know all the intricacies, and I look forward to talking to you during the interim now too, to understand it more. I just want to go back to the intent of this bill, and this committee has worked on this subject more than I have, and I respect that and want to make sure that I acknowledge your all's expertise in this. I just want to bring it back to this bill was not written for the insurance companies. This bill was not written for any pharmaceutical company. This bill was written for the patients and the folks that have to deal with the financial burden associated with life-saving and needed drugs and pharmaceuticals that they need to live their life, and making sure that wherever they're receiving, or if they are able to receive some sort of financial assistance related to the cost of their care or their drugs, that they can receive it and assist them and bring down their out-of-pocket maximums and costs. And I think that this bill provides that. And I want to speak to Delegate Krebs. You're right. There are a lot of unintended consequences with this, and it is important for you all and for us to recognize what those are. And I know that Mr. York and his group is going to be dealing with those in the future. I'm also concerned with that as well. This whole conversation has been talking about coupons. I'm not glib to the point that this bill would address and a focus on coupons, but there is more than just pharmaceutical coupons that this bill would potentially assist with patients when it comes to funding for, or a source of funding for their high expensive and cost drugs for their chronic conditions. And one last note, I would love to have a conversation with both the pharmaceutical companies and the insurance companies in the interim about this, because at the end of the day, this conversation that's happened before I started talking goes a lot deeper than just this particular bill. And I would love to see everybody get their act together and bring the cost down for one, insurance and for pharmaceutical costs. But unfortunately, the world we live in just shows that we have folks that have high costs and high bills when it comes to paying for their care. And this bill tries to address that. Everything in between from today deals with a larger and broader problem that I think we're all aware of. And I just wanted to bring that point up before I leave. Thank you, Chair Colson, for giving me the opportunity to speak.
Thank you, Delegate. Thanks for being able to be here. We're going to stop the conversation on HB 167 right now and move to HB 34. So Brigida, if you want to stop sharing the screen and make sure that the folks who have an interest in HB 34 are in the room. And I'm going to ask Delegate Rosenberg, are we there?
Yes, I am.
Okay. Yeah, there you are. So Delegate Rosenberg, would you just, before you speak, Lisa, let's go back to HB 34, State Department of Education and Maryland Department of Health, Maryland School-Based Health Center Standards, Telehealth. Lisa, you want to tell us what it does?
This is an emergency bill that requires the Maryland State Department of Education and the Maryland Department of Health to authorize a healthcare practitioner at a school-based health center to provide services through telehealth consistent with specified provisions of the Health Occupations article. The bill prohibits MSDE and MDH from requiring an approved school-based health center from submitting an application or seeking approval to provide telehealth services, or establishing requirements for school-based health centers to provide telehealth that are inconsistent with specified current law.
Okay, thank you, Lisa. Delegate Rosenberg, do you want to speak to the bill for a moment?
Yes, thank you, Madam Chair and members of the subcommittee. This bill would enable our school health centers provide the care that they are now providing in person to also provide that care via telehealth. It would be treating them to that extent like other healthcare providers, but makes no change in what services they do provide. It merely says, and importantly says, that those services would now be provided by telehealth. This committee went to the full committee and then the House floor, and one of the handful of bills that was actually signed this past session, this past year, emergency legislation expanding telehealth. School health centers were not included in that legislation. This bill would rectify that omission. Thank you.
Thank you, Delegate. Now, Delegate Saab, you held the bill last week. Did you get your questions answered?
I did, and I think Delegate Kipke had put an amendment to the bill. I guess we can maybe jump into, excuse me, discussing the amendment.
Do we have a copy of the amendment?
Yes.
I emailed it to the members and I hope everyone was able to get it. I emailed it this morning.
Okay. Delegate Kipke, do you want to speak to your amendment?
Thank you, Madam Chairman. I am trying to find the amendment in our complicated world that we're living in here. 1 second. Let me try Googling or searching for Lisa. Got it. So concerns were raised by Maryland Right to Life, and I also reached out to the Maryland Catholic Conference to understand the concerns better. Obviously, it was raised that in the testimony that we received that bills like this, bills related to telehealth, could potentially one day expand access to abortion services. The concern raised and shared by the Catholic Conference and Maryland Right to Life is that there is the potential that the FDA will change their acceptable use of certain abortion medications to allow them to be administered through telehealth. There is also some financial interest for certain parties to push that forward. And it was also allowed under emergency authorization because of COVID. The amendment that I have would clearly prevent that from being allowed in a school-based setting, just like it's not currently allowed. The concern is a change, and therefore it could be allowed. So the amendment I have that was prepared by Lisa basically just would codify or make it completely clear that anything related to abortion would remain the same as it is today, even if the FDA's guidance or changes on those abortion medications. So just to be clear about it, this isn't allowed to take place today. This amendment would just make it clear that whatever changes take place federally or at any other level of government, that is not allowed under the use of telemedicine in school-based health centers. So with that, I would like to move the amendment.
Is there a second?
Second.
Okay, it's been moved and seconded. Discussion on the amendment. Please use the raise hand function. Delegate Rosenberg?
I don't believe I have a copy of the amendment. Lisa, since I'm not on the subcommittee, was I not sent it? Or could it be sent? I don't know if Robin Elliott has it either.
I'm forwarding it now to you.
Thank you.
No problem.
Well, I would say first that this is not, this is speculative, and that should be a separate bill if we are to address that issue, so that there can be a full airing of the what would be the implications of such a prohibition, and that an amendment to a bill in subcommittee is, especially when it is, as you have indicated, not needed at the current time. It is speculative, and current law would not permit it, because there's both federal law and then there's budget bill language that we have regarding Medicaid funding. And that might be the better option to discuss this issue than an amendment to this bill at this time.
Thank you. Delegate Krebs.
Thank you, Madam Chair. Doug Roseberg, he actually made my argument that I was going to make. I mean, right now, this just basically holds us the status quo. And if indeed something does change at the federal level, it would force us at that point to say, what are the implications of the new policy? So it would not just be automatic auto drive if federal law changes. So I think his argument is my argument that this just makes sure that we have codified in current law our current practice, and anything that changed federally, it will come back to the state, and we will look, instead of speculating what may happen, it will come back to the state for us to have a good discussion about what the federal law changes were. So for the very same reason, I think we should just codify this, and then if things change, we can make that determination at that point in time. So I would support the amendment. It doesn't do anything except codify what this body has done to date.
So I don't see any other hand. Ms. Bogley?
Thank you, Delegate. I just want to express the urgency of this amendment that has been moved. Maryland already has taken an active role in removing the Food and Drug Administration restrictions on the remote prescription of chemical abortion pills. Maryland backed Baltimore City in a lawsuit against the Food and Drug Administration to lift those restrictions. And Maryland Attorney General Brian Frosch has already sent a letter to the Food and Drug Administration urging them to move those Food and Drug Administration restrictions. Those restrictions are put in place for the health and safety of women and girls because of the dramatically increased risk of complication and death due to chemical abortions as opposed to surgical abortions. And what data is showing is that they are 4 times more likely, chemical abortion is 4 times more likely to result in complications, including infection, severe hemorrhaging, loss of future fertility, and even death. 4 women have already died in the United States. 24 women have already died in the United States through this drug. And our concern right now is that data really is not complete on the complications surrounding this drug. And the reason that that's happening is that we're finding about half of women that experience complications from chemical abortion pills are reporting to emergency rooms rather than the abortion providers for follow-up surgery or urgent intervention to stop hemorrhaging, or to, it doesn't get that information is not being reported by hospital emergency rooms. And so the numbers of complications are severely underreported. So right now, as in terms of Maryland law, the only restriction that I see in Maryland law, and attorneys that have weighed in on this on our behalf, is the Food and Drug Administration's restrictions about, on the tele-abortions, on the remote sale and prescription of chemical abortion pills. There hasn't been something adopted in Maryland MSDE regulations for school-based health clinic standards. Right now, those school-based health centers are already allowed to engage in, of course, sexual reproduction education, abortion counseling, and abortion referrals out to surgical abortion facilities.
Oh, Ms. Bagley, I'm going to have to stop you because you're being a little bit repetitive, but I also need to correct the last statement. Page 24 of the MSDE standards for school-based health centers specifically prohibits any information or counseling around pregnancy issues. So that is specifically prohibited. Seeing no other committee members, I'm going to add with hands up, I'm going to ask the committee to consider the purpose of this bill and the reason that it is an emergency bill. School-based health centers are closed in many districts where schools are not open. These are primary care centers for children who are economically vulnerable, who may not be getting any primary care right now because they are not allowed to do telehealth. So for those children, I am asking you to think, we don't need to be speculative. Delegate Krebs, I would argue that if the FDA changes its rules, then we deal with that instead of dealing with it in this bill and being speculative and around what might happen and potentially holding up services for our most vulnerable youngsters. So with that, I'm going to ask if there is a motion.
Madam Chairman.
I'm going to ask for a vote on the bill, but was that Delegate Rosenberg? Oh, Delegate Saab. Delegate Saab, yes.
So I appreciate all that. And I just think, I don't think this would delay anything. I mean, we have done many speculative bills in the past based on what the federal government would or wouldn't do. We did it with Obamacare and we did it with the ACA. So I don't see any harm of putting something that will not delay anything and just basically codify what's already in practice. Nothing will be delayed.
I understand your opinion. Delegate Morgan.
Thank you, Madam Chair. I was going to echo what Delegate Saab just said, that I don't see how anything would be delayed by having a simple amendment, which is already in practice and what we do today. I mean, that's the intentions of, you mentioned, what was it, page 24 of some manual? Well, this would just add it to the bill. So I don't think there would be much harm in doing that. And we can go ahead and just move the bill today.
Delegate Kelly.
Thank you, Madam Chair. It's interesting for me to hear my colleagues say how this wouldn't delay something and it's a simple amendment. Just from my perspective, it would cause significant delay because there's no way I could possibly support such an amendment. It's clearly political. It has a political agenda. And we know that we're all on different sides of this very hotly contested political debate. And I would concur with the subcommittee chairman when she says, let's not let the kids and their need for access to basic health care get lost and bogged down by this major political debate that we all know what side we lie on already. And I think it's a tragedy to let the kids who need access to medical care have that care delayed so that we can have this debate on a totally different political issue.
Delegate Krebs, is your hand up again, or did you? Okay, Delegate Krebs.
Thank you. And listen, I think the sponsor of the amendment, the issue is we don't want this to be political in this bill. This is a really important bill. Community-based health centers, making sure that they can operate right now in telemedicine is really important. What I think the amendment does is codify and says we're not going to be on autopilot for whatever the FDA does. Good, bad, or indifferent, we're not going to be on autopilot. We want to have that discussion another day, and it will fall in along political lines in another day. But for today, we just want to focus on the bill at hand and get it done. And so I don't believe this is a political discussion today. It's just basically saying we will in this chamber have that discussion if something else changes down the road, and do it in a determinative way instead of just putting it on autopilot, whatever the FDA says. So I would just suggest that as important as this bill is, why tie it up with just putting it on autopilot, and just the amendment really doesn't change anything that's happening today. So that's my position on it.
Thank you, Delegate Krebs. I'm going to push back a little bit because if it's not political, why wouldn't we be including things like, well, school-based health centers can't do appendectomies. School-based health centers can't do tonsillectomies. School-based health centers can't do, any myriad of things. They do primary care and dental care. And that's what we want them to focus on. So the state of Maryland doesn't automatically follow everything. We can have that debate if we need to later. But right now, I think, as I said before, we need to focus on the services that these youngsters are getting, or have not gotten literally in a year, and we need to get them now. I will take Delegate Saab, and then I'm going to take a vote.
Thank you, Madam Chairman. I don't think it's political at all, and I still not convinced, or anybody has really articulated why would this delay any services. Nothing would be delayed. It's just really codifying what's already in existence. So can someone explain to me how would that delay anything?
I think that Delegate Kelly tried to do that and Delegate Young, Louis Young, do you want to speak to that, or are you going to speak to something else? There we go. You're off.
Which Delegate Young?
Louis Young.
Okay. I'm going to recommend we table this discussion for now. This is taking us in a totally different direction. We were going to hard stop at 12:30. I think many of us need to do that. And this is no simple conversation. It blindsided most of us. And I'm going to agree with my colleagues that it is political, or as another colleague just said, we would be discussing other issues as well. I think this needs to be tabled to a future time.
So I'm going to ask you, Delegate, if we not table it, I'd like to take a vote on this amendment.
Okay.
And
Okay.
then if I
Chair's prerogative.
And then I get a motion on the bill, we'll take that on the bill. So with that, I'm going to call for a vote on the amendment, on Delegate Kipke's amendment. Those in favor, so anybody who has their hand up now, please put it down. And those in favor of the amendment, and these are committee members, only committee members, raise your hands. Those in favor of the amendment.
Karen.
Now, Louis Young, is your hand supposed to be up? Okay.
Thanks for with us, Karen.
Okay. So,
Put it down.
Madam Chair, someone assist me in taking my hand down.
Delegate
yeah, I just want to still make you aware that my video is not working. So I just, I want you to be aware of that because you're doing hand votes.
Thank you. Thank you very much. I'm going to ask for your vote. Okay. Let me go to page 2 just to make sure I didn't miss somebody. Okay. I don't see anyone. Those opposed to the amendment. So put your hands down now. Everyone put their hands down. Delegate Saab.
There's a delay. It's down.
Yeah. Okay. Just making sure. Those in favor, opposed to the amendment, please raise your hands. Delegate Hughes, your hand comes up.
I'm trying.
It's not my face.
All right, where do I go? Sometimes it comes up, sometimes it doesn't.
Under participants for me.
Are you trying to raise your hand?
I am.
I think there should be either under participants or reactions.
Reactions.
Depends on your version.
It's not reactions, and it's not.
Or sometimes it'll say more.
It's very moody. Sometimes it appears, other times it doesn't. When I want it to, it's usually not there.
Okay. Delegate Hughes, not Hughes, Delegate Louis Young, are you a nay
I'm a nay on the amendment.
On the amendment, okay. Okay, is there anybody else who's trying to vote who cannot vote because their hand won't go up?
Oh, there it came up. Okay.
All right, then the amendment fails. Is there a motion on the bill?
I move the bill.
Delegate Kerr moves, Delegate Kelly seconds. All right, all hands down, please, unless you're voting for the bill. Those in favor of the bill, please raise your hands as written.
What is Robin not voting?
I'm not on this committee. I'm waiting for my bill to be heard.
Right.
My apologies.
Okay. All right, please put your hands down. And those opposed to the bill, please raise your hands. Opposed to the bill. Okay. All right, the bill carries. All right. Thank you all for that discussion. I appreciate it. I know that I would like to do one more bill, and that's Bill 107. If folks can stick with us for a little longer, and I apologize to the folks who are here for 162, 303, and 123. We are going to have to hold these until next week, or we may have to have a meeting. We may have to have a meeting at an off time. So please watch your emails, particularly on those bills. So now I'd like to do House Bill 107, prohibition on vending machine sales of drugs and medicines, repeal. Lisa, what's the bill do?
The bill repeals the prohibition on the sale, distribution, or disposal of drugs, medicines, pharmaceutical preparations, or medicinal preparations by means of a vending machine or similar device. And it also makes technical changes and corrections.
Okay, Delegate Lewis. No, you're here.
I'm here.
Okay, there you go. Want to speak to your bill for a minute?
Yes, thank you so much, Madam Chair, esteemed colleagues. You heard this bill in committee. This is really one of those lovely, simple bills that reverses a prohibition that is holding back the state's ability to make over-the-counter medications accessible to the people of Maryland. This is a bill that will make it possible for the people of Maryland to access over-the-counter medications in a way that's socially distanced, that respects the public health measures during this pandemic, and that we hope will also expand the ability, the geographic distribution and number of outlets, vending machines, where people can get things that they need. So you heard all that in committee, and I'm grateful that you're giving it special consideration in this subcommittee hearing. Here to answer questions, along with a few of the other bill stakeholders.
Okay, thank you, Delegate Lewis. Thanks for hanging in there. Are there folks who have information to add that was not perhaps heard in the hearing? Okay. All right, not seeing anyone. Questions from the committee? Anybody who Delegate Morgan?
Just want to double check and make sure I understood it because I can't really remember from the hearing. Is this only for over-the-counter medication? It's not for any type of prescription?
Yes, sir. It's only for over-the-counter. Anything you can buy over-the-counter right now, today, at a pharmacy, outlet, Target, whatever in Maryland, you'll be able to also access in a vending machine. So wouldn't it be nice to, like, if you needed some Pepto-Bismol because General Assembly gives you, like, you know, acid reflux, there was a machine down the hall. Wouldn't that be great? So that's what this would make possible.
All right, thank you.
Thank you.
Any other questions from the committee? Do I have a motion on this bill?
Move the bill.
I've got, it's moved by Delegate Kelly. Do I have a second?
Second.
Second.
Second, was that Delegate Lewis Young?
No, sample Hughes.
Sanford, Delegate Sanford Hughes. Okay, any other discussion on the bill? Okay, those in favor of the bill, please raise your hands. Okay, those opposed to the bill, please raise your hands. Delegate Saab, are you opposed?
Yes.
Okay. Delegate Lewis Young, are you opposed?
No.
Delegate Morgan, are you opposed? Okay. Okay. The motion carries. We'll recommend favorable to the committee. Thank you all for your patience and your indulgence today. I apologize for the lengthy discussion on 167, but I thought it was really important for the committee to understand, have a better understanding of the impact of that bill. As I said, please watch your emails, because we could potentially have a special meeting of this subcommittee to make sure that we can get through the many bills that we have. So with that, I ask you to all have a wonderful afternoon, and the HGO hearings will begin at 1:30 today. Thank you very much.
Madam Chair,
Yes, Delegate Bandari.
what is the bill number that we voted just now?
107.
107.
Right.
Just a second. Okay, I'll vote for that bill.
Okay. Okay, great. Thank you all very much. We'll see you on Zoom shortly, I'm sure. Thanks.